The basic problem of addressing cage failures is one that we lack foundation. The foundation, number one, in identifying what is a fusion. We have only very loose criteria. The only absolute gold standard criterion, as said before, is surgical exploration. And we don't even know what a fusion means in terms of outcomes. There's a lot of debate on the various factors that come through. Material designs, as Carlo had discussed, play a great role in this whole debate. There's a great apprehensiveness now about using titanium in arthrodesis procedures because we have this fear that we can't see the bone healing around the titanium. Hence, the two-pronged approach from industry. Number one, bring allografts onto the market, which are not FDA regulated, at least so far, even if they're highly machined. And number two, come up with radiolucent materials. The most commonly used one is obviously the Brantigan cage with carbon fibers. Despite a negative track record in artificial knees and joints, it had resumed a very high profile career with the DePuy cage. There are other biomaterials that are coming out now. A material called PEEK will be available in the very near future from a number of manufacturers. It's a polyethylene device, and again, the touted advantage is that this kind of a substance allows you to see the healing of the bone, whether it's with a sentinel fusion or whether it's looking through the cage. These are probably fallacies in a short sentence. Basically, we have to use good surgical technique, and basically we need to have a pretty much comprehensive arthrodesis if we want to rely on a interbody fusion to work. We need some form of a supplemental fixation, such as Chris pointed out before, with transarticular or transfacetal screws. We need some form of a help, at least, for our implant situation to grow through. How do we identify things, and what is a problem patient? The main problem patient is the individual who's had a technically well-performed procedure done for the right indication, hopefully, by a good surgeon who's experienced in the procedure, who comes back despite these best efforts 6 months later, and 6 months is usually the tide mark, and is still unhappy with the result. Thank you. So again, the main thing is, here we're in the business of converting our mobile spine, previously mobile spine, to a long bone, and we still don't even know how to address a fusion with elegant diagnostic tests. And cages have had an enormously wide track record. Again, if you look at the BAK data from Kuslich, it's a 92% rate of success. If you look at Gary Franklin's Washington State LNI data, it's a 26% success rate. Obviously, this 4-year-old thought that this was a very amazing substance that we put in. And again, we have different categories of implants now, with radiolucency being a touted advantage to try to diagnose this. Sadly, and I'll shortcut this talk in this part here, these radiolucent materials have not enhanced our ability to diagnose unions or non-unions. The Brantigan cages, for instance, that are radiolucent, there have been many patients now who've had motion in the Brantigan cage with what seemed to be a good bony healing. Again, we have to select our patients carefully. That's probably the biggest key of success that we can have. And we have to avoid mishaps. Probably the most common mishap is to operate on a patient who has hip arthritis, for instance, such as in this lady, and do an interbody fusion on this patient who actually really, by all means, had hip arthritis pain, but who now, after one of the cages was probably not placed optimally, had a new onset leg pain and weakness. So we've opened up a new can of worms in a surgery that probably was unnecessary. So the technique paradigm is obviously important. We need to place our devices properly, and we need to do the procedure well. Cages are potentially dangerous, such as discussed with Chris before. We need to make sure that we do not violate the central neural canal, such as done here with this cage, or more commonly, that we don't hit the foramina. The foramina are a particular problem. If we use a C-arm as a reference, the lateral plane will usually give us a false sense of security. The posterior vertebral body wall is frequently convex, and a cage that is just a little bit off the center has a very high likelihood to be actually impinging upon the root. Hence our suggestion to make the cages be in the center of the vertebral body and not make them flush with the vertebral body as seen on a lateral projection. So the persistent back pain problem, over 6 months, everything looks good on plain films. Should we stick our head in the sands? Hopefully not. The basic workup is very straightforward. We want to get our flexion extension films and our AP. Everybody knows that. That's a standard thing. We look for radiolucency around our implants and loss of reduction or alignment height. Clearly, a technetium-99 bone scan, as imperfect as it is, with a SPECT enhancement after 9 months should be cold if a full arthrodesis has occurred. Definitely after a year, after 12 months, a hot bone scan in the cage area, as isolated on a SPECT, is a high index or raises a high index of suspicion. And finally, a CT and myelogram with hardware suppression program, which is now routinely available and it just requires a little extra attention, is a absolute conditio sine qua non, the test to get if a patient falls into that paradigm. It's debatable whether a patient should get electrodiagnostic tests. It's decision-making. If a patient has a lot of leg symptoms, it's probably reasonable to objectify the data and differentiate acute versus chronic changes. The classification differentiates between occult non-unions, meaning the patient has persistent pain, there's a positive bone scan, but there are no destructive changes, there's no motion present. In contrast to overt non-unions, where there is discernible motion and there is some osteolytic reaction discernible around the cage, regardless of the material that it is. Overt cage failures don't differentiate between the material. It's fully irrelevant whether it's an allograft, whether it's metal, whether it's PEEK or whatever it is, carbon fiber. You will see osteolysis, you will see a conjunction of sclerosis with destruction in close proximity around these cages. This constitutes a crass biological failure of the implant and requires, again, intervention. If left untreated, these will be a problem. Again, this is usually a crass mechanical failure. We have to always consider the possibility that this is an infection, especially in our immune-compromised population. And again, the end result will be it's invariably progressively destructive. It will not heal, even if we put these patients into a brace. They will displace more over time, and there's a high likelihood of these due to kyphosis of the lumbosacral spine going and causing neurologic secondary impingement, even if the cages were well placed initially. And again, the treatment is very straightforward. That's a lie. It's in principle, straightforward treatment. We do need to take these particular cages out and do a segmental posterior fixation. This patient required instrumentation above and below due to severe stenosis at these levels as well. But these are very difficult procedures and very much are aggravated by the fact that metal cages are very hard to remove, be it from anterior or posterior. Some manufacturers have offered osteotomes to take out these cages, and I found those to be actually highly destructive. It's much simpler to put a 1/4-inch osteotome into the core of the cage and then use a vise grip and turn it around. You'll be amazed how easy it is to twist out cages. All you need is a 1/4-inch osteotome put into the core of the cage. You always have to consider the possibility of an infection. Just as a reminder again, whenever you're dealing with an overt cage failure, an infection should cross your mind, should be adequately addressed in terms of your treatment. One argument in favor of allograft cages is that they're eminently more revisable than metal cages. For instance, this patient with an allograft cage clearly went on into a failure. You see the scoliotic and the kyphotic collapse here with a progressive loss of reduction. The patient had a significant spondylolisthesis and required a posterior decompression and fusion. This is all done from posterior, and the allograft literally fell apart upon just osteotomizing it a little bit. It's like a dried mummy. It falls to pieces once you touch it. You can fragment it and you can remove it in piecemeal fashion without any undue neural entrapment. The occult non-union is a much bigger deal. This is the scenario where you have nice-looking flexion extension x-rays. There seems to be bone forming. You get a reasonably good quality CT scan with hardware suppression. There's bone inside the cage. There's bone around the cage. The patient did well for a while and then develops new pain. And you obviously are worried about adjacent levels, and you're worried about this level having somehow broken loose. Carlo showed you the very small contact points that most of the metal cages have. And this is the scenario taken a further step beyond that. The technetium-99 bone scan has a hot signal right in here. And what do you do with that? We have to go inside the cage to understand what happened here. But again, we have these small contact surfaces in a cage that hopefully was packed tightly. I'm still amazed with the large amount of cage revisions that we do, how it seems that oftentimes surgeons imagine that there's some magic influx of bone occurring within metal cages. This is certainly not the case. You need to create a very packed environment and hope that this cage will then conflux. Carlo showed this slide before. This is a cage extraction that we did a number of years ago. And again, we're very impressed to see that there was actually a very nice healing taking place. There's osteoid formation taking place. In contrast, if we have osteoclast formation, that usually leads to a reactive osteoblast formation that will continue and not subside and mature after about 9 months to 12 months. So the osteoblast propagation stops in a healthy ingrown cage, usually at 9 months, whereas if there's ongoing osteoclast activity, osteoblastic reactive activity will persist, causing a positive bone scan. What does this mean? Obviously, one scenario is a very clearly stable incorporation, but the other one can be subseparated into a stable non-union. We know that from the fibrous healing that we talked about in the uninstrumented posterolateral arthrodesis before. Very rarely do these stable non-unions actually proceed to an unstable non-union over time. It usually requires a mechanically unfavorable standalone environment. The treatment of the occult non-unions is far more difficult. It is my personal suggestion that you just serially assess these patients, reassure them. I found that most patients are actually very reasonably reassured that their pain is not necessarily in the head and will go about their life. But they do need follow-up x-rays, and they do need to make sure that there's no osteolysis occurring. In patients who have standalone cages, it is probably reasonable to offer a posterior segmental instrumentation, leaving the cage with suspect or partial union in place, but using a proper iliac crest graft and, if need be, a supplemental decompression. It is also reasonable to leave the cage in those scenarios and actually do a discectomy around them, from posterior, for instance, and supplement with loose bone graft the environment around the cages and violate the end plates to get some bloody ingrowth. We've actually been reasonably happy with this solution, again, leaving the cages in place and not very ferociously trying to knock these partially incorporated cages out. So in conclusion, anterior column reconstruction techniques have really improved, I think, our arthrodesis rates and have decreased our hardware failure rates of posterior devices, but it is an adjunct to posterior procedures. And standalones are probably very rarely indicated. Those are the patients where we have to suspect these non-unions to be more of an issue. And again, the basic result of a workup is either, if your patient has ongoing pain, that the patient is normal, you suspect that you have a stable environment, no neural impingement present, and you mainly have to reevaluate your rehab paradigm. If you have an occult non-union, you can consider posterior segmental fusions or continue to observe. And only the overt non-union, the destructive process, requires a comprehensive and very difficult and frequently frustrating anterior and posterior revision surgery.
The next talk is going to be on the arthroplasty. This is new technology, and patients are now coming in constantly asking me about when should I get a disc replacement instead of a discectomy or something. And so I want to update you on the status of disc replacement, both lumbar and cervical spine. I'm going to kind of review what the current state of disc replacement is. I think we'll start with classifying. There are different types of disc replacements. I think the best will be biologic. If we can inject something in there to regrow the discs, will probably be the best way. There's nuclear replacements where you just replace the nucleus part, kind of like with putting a new pillow in the nucleus. And then there's total disc replacements where you're replacing really the end plates and the nucleus and to some degree the annulus. Well, first of all, I'm talking about the lumbar discs first. What would be the indications for a disc replacement? Well, I think 1 or 2 level disease, discogenic low back pain, who was otherwise a fusion candidate. They failed non-operative therapy, and they've passed whatever psychological assessments you do. Well, biologically, I think the question is, can we regenerate the disc? This would be akin to what Ponce de Leon was looking for, the fountain of youth, because if somebody could put a needle in, inject something into me, and grow all my discs again, I might be a 5 handicap golfer again. Well, Jim Kang from Pittsburgh has done this in rabbits. And they use an adenovirus vector. They code in a gene that causes these cartilage cells in the disc to form